Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, plastic surgeon in Beverly Hills, along with my co-host and associate surgeon, Dr. Millicent Rovelo, also a plastic surgeon in Beverly Hills. How are you?
I've been better.
I know.
It's been an evening.
So, do you want to do this podcast?
I do.
Okay.
I want to do this podcast. It just took a really long time to get here because the studio is lovely, but it's really far from our office. Actually,
I think it's 2.7 miles.
It's 2.7 miles, and it took me an hour to get here. So that happened. And then they tried to make me pay for parking because I'd passed the hour where I could get in for free. And then there were other things. And so I'm here. I'm here at Melrose Podcast Studios.
Notice a little Justin Cabernet in that cup.
I had to put a little bit of wine in this water bottle.
I know.
Because I just had to.
And I think that's fine. You know, it's
going to get me through.
It's that hour. It's, you know, it got late on us, didn't it? It's like.
Yeah. But I'm happy to be here because
Good.
What are we talking about today?
We're talking about rib grafts, either, and this is in the context of rhinoplasty. Should you prefer or use the patient's own rib cartilage for revision rhinoplasty or primary rhinoplasty versus a off-the-shelf product like an irradiated rib cartilage from MTF? I will note that I am a consultant for MTF. MTF, which is the Musculoskeletal Transplant Foundation, which is a not-for-profit organization. I think they do make a lot of money. I think they do make a lot of money, but they make a lot of money for the foundation, and they have incredible products. So I just, and we like MTF, but I am a consultant for them, and just to be like all full disclosure, Sunshine Act, whatever it is, that needs to be set. With that said,
I have a question from the audience.
Yeah.
Are there actually other brands that make rib, irradiated rib, or donor rib?
For sure.
Is it just because I'm only familiar with MTF? No,
there you can get ribs of all kind. There's Tudoplast. There's irradiated ribs from other bone banks. MTF is not irradiated.
Right.
In fact, it's interesting why I've been involved with them for so long, because originally the process that they use to treat the ribs before they become sort of inert and can be used in other humans, because normally you can't transplant a rib from one person to another. It would get rejected like anything else. You'd have to be on immunosuppression and all that sort of thing.
Which is why historically they've been radiated.
Right, which gets rid of all the living tissue and a lot of the antigenicity, which means that it becomes less reactive when you transplant it into another person. But the process was really one developed by a company called Kenzie Nash, and I worked with them a long time ago. And so I have a history with the processing of these tissues. They process pig peritoneum with it. They use it for fat. You know, this is where you can also get
Renuva.
Yeah, Renuva, the allograft fat, which I don't use very often. But in fact, I don't use MTF ribs that often, but I do use them. So why would you pick a off-the-shelf rib versus the patient's own rib?
An autologous rib.
Shout out to Gabby.
Shout out to Gabby.
There you go.
So it's
the autologous Rex.
Autologous is the fancy doctor word for something that comes from your own body, but you can call it autologous. That works too. And
it's autologous.
It's
That's how we typically say it.
Autologous.
But sometimes we have some creative pronunciations around the Roxbury Clinic and Surgery Center. We like to carry those out.
Yes. And this is rib that, as the name says, comes from your own body. And so this is an additional procedure. It's an additional surgery site. And in your hands and the way your fellows do it, it's a typically very small, several centimeter incision. And you can give more detail on this, but it's coming from your own body. It's a piece of your own rib that is then being used to carve into grafts for a usually revision rhinoplasty, although sometimes in primaries as well. So it has a lot of great uses, which we're going to go into, but the downside of it is that it is a separate donor site, and sometimes patients don't want that, or they're not candidates for it, so that's why you would go to the kind of off-the-shelf rib, and you're not going to tell us all the cons and pros of each.
Well, autologous rib I like because it's the patient's own tissue. The downside is, like you said, there is another surgical site, but it's not kind of a big deal. Back in the day, it used to be a big deal because the way the harvest was done, Used to be a big incision, cut through the muscles. It hurt for 6 months. Now we do a muscle sparing approach, tiny incision. We part the muscles. We don't cut through them. So patients, they say it aches. I'm not going to lie.
Yeah.
There are people that, sometimes need a little bit of a block there if it's aching. But, I had one mom carry her kid in the next day after surgery on the hip that I took the rib from. I was like, isn't your rib hurting? She was like, what, this?
Yeah.
She's like, how's my nose?
That's a mom for you.
So,
and to be clear, it's the cartilage of the rib, not the bony construct.
Correct. And there are instances where we will take an osteocartilaginous rib graft, but that's very rare in my hands anymore. Typically, we use the rib cartilage to make grafts, and people think we're just going to take the rib out and stuff it in their nose, and that's their rhinoplasty, and that is not how it works.
You don't just put a rib on someone's face and call it a nose?
No. Back in the day, that was kind of how it was done. You take out an osteocartilaginous rib, you take the junction of the bone and the cartilage, because the rib bone comes around from the spine and wraps around the chest, and then there's a junction with the sternum where it turns to cartilage.
Right. And it's a fairly sizable, size.
It is.
Length
It's
of
usually
cartilage.
anywhere from, depending on where you are on the rib cage,
Right.
anywhere from 3 centimeters to 8 centimeters.
Yeah.
Do we want to do centimeters or centimeters on this podcast?
Centimeters for the love of God.
Yeah, because most people say centimeters.
Because we're not douchebags.
I know, and all of a sudden when people get into medicine, they start saying centimeters. Ew, it's 8 centimeters. It's not, we just
We're
say
in America.
centimeters.
Centimeters.
Yeah, I guess. So anyway, back to that. So anyway, it could be that long, and it is definitely one of those things where you look at it and say, that's a lot of cartilage. But then in a revision rhinoplasty, you start carving it up and you're like, thank God I have this big piece of rib because I need spreader grafts, a caudal septal extension graft. I need a caudal septal reconstruction graft. I need some sort of lateral curl strut grafts. I might need some dice cartilage. So having lots of rib is really nice. And when
really
you
helpful.
get a big old 8th rib or a 7th rib, life is good.
So satisfying.
It's so good. And I can do anything I want with all that rib cartilage, and life is good.
And so let's talk about briefly why you would need this. Like in a primary rhinoplasty, we'll talk about maybe why you would need it for primary. But typically in a revision, you need it for a couple of reasons. Number one, the septum that you would usually use to take cartilage grafts from is usually gone because it was taken with the first primary rhinoplasty, and that's your go-to source for grafts. So when that's already been harvested and already taken, and you have a big deal rhinoplasty that you need to do, you need some solid, helpful, strong support. You can't always get that from the ear, if ever, so you need something like a rib. Rib's a little bendy, or the ear's a little bendy.
The ear is just really soft.
Yeah, and you need support.
You hear that? Rib cartilage.
Yeah, that's good.
It's not just for breakfast anymore.
Just for breakfast.
This is
ear cartilage is
what are you going to do with that? It's just, it's soft, and it will lose the battle in a scar versus graft kind of situation.
Which is a revision.
Yeah. So in a revision situation, you've got scar tissue. It's going to pull on that ear cartilage, and the rib, like I said,
it fights back.
It's got some strength to
Yeah.
it. It's got some oomph.
Yeah.
So we want that. And even septum, by the way, isn't awesome in a revision situation.
Yeah, even if you have it. It's so much thinner that septum is that inner kind of piece of cartilage between your right and your left nose, and it separates it down the middle. It's still kind of bendy sometimes.
And I'm going to put this out there right now. If you don't like it, you can send it right back.
Send it right back to you.
I argue that sometimes in a primary situation, you get in and look at that septum and you go, this is not awesome cartilage. Yeah. And you know that you really wish you had rib.
Right.
And it's not all cartilage is created equal. And some people have softer cartilage. There's a whole spectrum. Cartilage is basically proteoglycan, some sort of collagenous framework, and it has a perichondrium to it, a lining to it. And it has elastin, and it has all, it's got a lot of other things that compose it, but it's variable how it's made in person to person, and not everybody's cartilage is awesome.
Yeah, and that's why sometimes in primary, especially your ethnic rhinoplasties, your septum is not as large or big or structural as you need it to be, so you go to rib.
Of 100%. And for instance, a lot of and I just don't like this term, Asian rhinoplasty, because Asia's a big place with all kinds of different people. But typically that's the term that we use to refer to a rhinoplasty where we're building up the bridge some because it's very low and needs to be built up, and doing some sort of tip work to get more definition and to bring the nostrils in and make the alar base narrower. That's a typical kind of Asian rhinoplasty that we think of. In that situation, two things are really tough. The cartilage that is there is very soft and flimsy, and so it's not very reliable to do anything with it. And then you also don't have a lot of it because the septum is usually typically small. So you kind of either need to go say to yourself, well, I'm going to get volume from the ear cartilage, or I'm going to get volume and strength from the rib. And so I opt for rib cartilage. I just think it's better in Asian rhinoplasty. I think it does the job, and you have a reliable reconstruction that's going to last over time.
Right. So these are all the reasons why you would want a rib cartilage. And so we've discussed why you like the autologous version. What are the reasons or benefits of using the off-the-shelf rib?
You don't have a separate surgical site. You can just buy it off the shelf.
Yeah.
And so you don't have to cut the chest, et cetera. You can get as much as you want. Like you could buy 2 ribs or 3 ribs or whatever you want. And so you get
Ribs
the volume. That's right. It's like Tony Roma's around here. But Tony Roma's a place for ribs.
Place for ribs.
Yeah,
Jay Calvert.
I know Jay Calvert's a place for ribs. But the MTF product is great because it comes in lots of different sizes and shapes. With the irradiated rib products that you get from bone banks, you kind of catch as catch can. So you might get something great, you might not, that you don't really know. And that's not a plug for MTF. It's just kind of the truth. I never know what I'm going to get. And the problem that I've found with irradiated rib is it's definitely it's kind of more washed out version of the cartilage, where with the MTF, I like the processing better because you get, it's still not autologous rib. It's not the same.
Yeah.
And there are papers written by, this guy and that guy that say, oh, it's the same. You can use them interchangeably. No.
Yeah.
I disagree. I'm sorry. I know what the data says, and you can shove any, manuscript in my face and say, no, see here, I do these operations. They're not the same. Yeah. And to me, they're not the same. And I'm not bagging on MTF. I'm just saying it is my finding, my, opinion that there are differences in the cartilage. It's just what you get. And
so real world, how does that play out in the patients?
And by the way, there are some patients where autologous rib just isn't patients 70 years old or whatever, they have calcified ribs. I've gone in to use a 42-year-old doctor's rib, and it was just bone. There was no cartilage.
Because what happens with age is usually that cartilage, which is a little bit pliable, becomes calcified over time. It gets calcium deposits. It gets brittle, and it's not as good a graft as it would be maybe when they were younger. So for your older patients, their own rib is less useful.
And I've seen younger patients where it's just,
and sometimes
it's bone.
It's bone.
And this 42-year-old doctor had no trauma. I asked her afterwards, what did you have this? Did you do that? No, never had that. Just
how it was.
So I was like, well, luckily I had a rib in the fridge, and we were able to use that. So in those situations, you're really happy that you can get an off-the-shelf product. So you need to be competent in using both types of rib cartilage. You can't just say, oh, I'll never need an off-the-shelf rib. You might. And you can't say, oh, I'll never need to take autologous rib. Well, when you've failed a few times with the off-the-shelf product because of the severe scarring, or you needed more strength or whatever, then maybe you do need autologous ribs. Yeah. So you should be able to do both.
And so that's what you see with the off-the-shelf rib, the MTF, is that it doesn't stay as strong. The support is not as great.
It's not as great. It can be brittle. It's harder to work with for me. And these are all like opinions. I'm sure we get some guy in here who, loves MTF and is happy they never have to cut the chest to get rib cartilage and says, I can do anything with it. But it's all about the results. So doing stuff with it and doing surgery, to me, is part of the process, but I want to see the results. You need to
and that's
have
what the patient wants
results.
to see. The patient doesn't care how hard it is for you in surgery.
They don't.
At the end of the day, they want to know, am I going to get the same result, better, worse? How is it going to last over
the in-between parts from I'm rolling into the operating room to 1 year out aren't as important to the patient as long as they get a great result.
Right. And do you feel you can get a great result with both?
I can. I just have to I have to modify my approach depending on is it a trauma case? Is it a revision rhinoplasty case? Is it a, primary rhinoplasty, Asian rhinoplasty? Like all those factors play into which cartilage is best for which situation. And the blanket answer, I can do anything with MTF, or I can do anything with irradiated rib, or I can do anything with autologous rib. I mean, yeah, you can do anything, but what are the results like? Because that's what counts.
I guess that's what I'm trying to pin you down on. What are the problems that you see with the off-the-shelf rib that you don't with the autologous rib?
Depends on the autologous rib, because sometimes the autologous rib is really brittle.
The best autologous rib you could ever have. Okay. And a 30-year-old patient who's like, no, I don't want the donor site. And so you use an off-the-shelf rib. So in that patient who would have otherwise had great cartilage but chose to not use it, what are the differences that you see?
Long term, there can be absorption. So it is still not your tissue, even though it's not, it's not benign and inert when it comes to, immunocompetency of the patient that you're putting this in. They're going to reject it in some way over some time. And maybe in 5 years it's gone, maybe in 20 years it's gone, maybe it never goes away, but you don't know. And so if it does get eaten up and chewed up, where are you?
Yeah. And you don't see that near as much with a nice, healthy chunk of your own rib.
Correct. With the autologous rib, I see, there are tons of people around Beverly Hills and Orange County that I've done ribs on that I see all the time. I forget that I did ribs on them. In fact, I was at a charity event one time and there were 12 patients of mine with rib cartilage grafts in their nose walking around, and I was like, I hope these ribs don't get mad at me. They were just they're all there. There were like tons of them. And, and that's great. But they all looked really good and I can follow them over time. So that allows me to see, I see rib grafts that I did 2010 that, I see all the time and it looks fine. And I see, people that I did, more recently and they look great. So it just is a matter of, following them out. MTF or irradiated rib, I think they do okay, but I've had some problems where I had to take people back and do a autologous rib. I had a friend of mine that I did her whole rhinoplasty with irradiated rib, and she was like, this is what I want. I was like, all right, and we did it, and I think probably 18, 24 months later we were doing it again.
That's disappointing.
Yeah, so I don't want to bag on any of the products because there are times I'll use them.
Sometimes you need them.
Yeah, and it's not that everybody's going to have problems with them. It's not everybody's going to get huge success with them. But I feel better if I can use autologous rib. I had a 68-year-old woman recently for Asian rhinoplasty revision. I said I'd really like to use a rib on this. You failed the other methods, so we did it. Her rib was perfect. It was amazing. We got the rib out easy. She said, this aches a little bit, but I love my nose. It's great. And it worked, and it looks fantastic. It's really good. And I've had a patient recently that was 52 years old and went in to get the rib cartilage, and it was just bogus. It was just trash, just brittle and calcified. And I was like,
nope,
this isn't happening. I need to get something off the shelf to do that.
So each one has its benefits, and it's really just a matter of what that patient needs and what in your hands is going to work best for them.
100%.
And just deal with the pain for a couple of weeks, people. It'll be fine.
Yeah, the pain is not terrible. It is a scar, I get it.
It is sore, but pain is temporary, and it grows back.
It does. It does. If you close the perichondrium or in the soft tissue and sort of protect it, then you'll get a connection with some type of cartilage. Right. It won't look like the original rib, because I've been back to get another rib on some patients for trauma, et cetera. And I always take a look at the harvested rib, and it's not awesome, but it's there.
It's there.
And you don't care anyway because you heal up from these things heal. They do well. I've had very few complications there. Pneumothorax is the big one everybody worries about. How many times you've gotten air in the chest? I can count 3 that I've had throughout my whole career. We've treated them on site, suctioned the air out, closed it up, no big deal. Yeah. Didn't leave them with chest tubes or anything like that. I've had some infections at those sites. They're few and far between. I think I can think of 2 that I've had to deal with.
Infections at any surgery.
Yeah, but they're pretty infrequent there. So, that's sort of the story. I don't know. I don't really have anything more on that, because I know people are probably listening to this going like, so which one should I use? Which one should I get? I'm having surgery. Should I have this or that? That is a discussion with your surgeon. That is a discussion about your situation. It is very custom, and it depends on a lot of different factors that you have to weigh that out for your situation with your surgeon and their level of comfort with each technique.
It's a big fat, it depends.
Yes, as many things
So
that we talk about are.
unsatisfying. Well, on that unsatisfying note.
This is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.